So let's set the scene. A 65-year-old smoker walks in complaining of a cough. Now, is it just a simple chest infection? Could it be COPD? Or is it something a lot more serious? As a final-year med student, you're going to face this exact scenario over and over again. So in this explainer, we are going to absolutely master the clinical approach to a cough. The goal? To make sure you can tackle it with total confidence and precision.
But before we dive in, it's really important to give credit where it's due. The entire framework we're about to use, the whole structure, is based on the fantastic work of Dr. Mohammed El-Naghi Mohammed. We're breaking down his structured approach today.
All right, here's our roadmap for today. First, we'll talk about why a systematic approach is non-negotiable. Then, we'll deconstruct the patient's history piece by piece. After that, it's on to the focused examination. We'll cover the key investigations, and finally, we'll tie it all together to really master the method.
Okay, let's get right into it. You know, a cough can be anything from a tiny annoyance to a sign of a life-threatening disease. Having a system, a structured approach, isn't just about being tidy, it's absolutely essential for figuring out which one you're dealing with, and doing it safely and efficiently. And this right here is the core principle you have to burn into your memory for finals. Your examiners, they're not just looking for the right diagnosis. That's only part of the puzzle. They're testing how you got there, your clinical process, your reasoning. A rigorous, structured method is the foundation that proves you can actually think like a doctor.
All right, the patient's history. This is where you put on your detective hat. Seriously, this is where the whole diagnostic puzzle starts coming together, and every single piece of information you gather helps you narrow down that long list of possibilities. And here it is, the complete framework for a rock-solid history. Let's walk through how each of these components logically builds on the one before it, letting you construct a really coherent clinical picture. Now, what's so cool about this is how the most basic info immediately starts pointing you in certain directions, right? An older patient with a brand new cough, malignancy has to be on your list. A patient who works with stone dust, you've got to think about silicosis. Someone living in a care home, well, you're leaning towards an infectious cause. See? You're already building your differential diagnosis from the very first sentence.
Let's use this as a running example for the rest of the explainer. Notice the two absolutely key elements here. It's in the patient's own words, and it includes a specific duration. This simple sentence gives us a precise, unbiased starting point for our entire investigation.
Okay, pay attention, because this slide is incredibly high yield. A top-tier answer in an OSCE or a written exam will always break down the cough using these characteristics. Is it a dry, hacking cough? That might suggest some kind of irritation or maybe even interstitial lung disease. Or is it productive? That points us more towards an infection or a chronic condition. And the sputum, is it green and nasty, suggesting a bacterial cause? Does the cough wake them up at night? That's a classic feature of asthma. These details, they're your most valuable clues.
But here's the thing, analyzing the cough itself isn't enough. You have to actively hunt for associated symptoms. Why? Well, because finding them, or just as importantly, not finding them, can completely change your diagnostic path and how quickly you need to act.
And these are the big ones, the red flags. The presence of any of these should immediately set off alarm bells in your head. They dramatically raise your concern for something sinister like malignancy or TB. So the crucial point here is you must always ask about them specifically, never, ever just wait for the patient to bring them up.
And remember to connect the dots. Everything is context. A history of getting chest infections over and over, that might point to an underlying issue like bronchiectasis. A 40-pack year smoking history is obviously vital if you're suspecting COPD or lung cancer. Oh, and don't forget the drugs. ACE inhibitors are such a classic cause of a dry cough.
Okay, so we've gathered our clues from the history. We've got a list of suspects. Now it's time to look for physical signs. The clinical examination is where we start testing those hypotheses we formed, looking for actual physical evidence that either supports or refutes our initial ideas. Before you even think about putting a stethoscope on the chest, your examination has already started. Just look at the patient from the end of the bed. Are they in distress? Are they using their accessory muscles to breathe? Is their respiratory rate sky high? Do you see finger clubbing? That could point towards lung cancer, fibrosis, or bronchiectasis. These first observations can give you immediate, vital clues.
Now for the cornerstone of the respiratory exam, auscultation. We're listening for two main things here. 1, the quality of air entry. Is it equal everywhere? And 2, critically, Are there any added sounds that just shouldn't be there?
And this slide illustrates the key distinction perfectly. Can you hear the difference in your head? Crackles are those short, popping sounds. That's the sound of little airways snapping open. It suggests fluid, maybe from pneumonia or heart failure, or the stiffness of fibrosis. A wheeze, on the other hand, is that continuous, high-pitched musical sound. That's air being forced through narrowed tubes, and it's the absolute hallmark of asthma or COPD. Knowing what they sound like and what they mean is a fundamental clinical skill.
All right, time to bring in the forensic tools. And remember, ordering investigations is not a random fishing expedition. Every single test you order should be targeted. It should be selected specifically to either confirm or rule out one of the diagnoses you've already carefully constructed from the history and exam.
Often, a chest X-ray is your first and most powerful investigation, and as you can see here, the findings can just dramatically narrow down your differential. See consolidation? You're thinking pneumonia. See a mass lesion? That raises the urgent suspicion of cancer. And what if it's normal? Well, that might lead you to think about causes like asthma or even postnasal drip.
And this is how you present your final conclusion. It's not just a one-word label. It's a definitive statement, and every part of it is supported by a logical trail of evidence that you have meticulously gathered every step of the way, from the history, through the exam, and finally confirmed by your investigations.
So we've walked through the entire clinical journey, from start to finish. Let's just pause and bring it all together. What is the crucial takeaway from all of this? And how does mastering this process set you up for success, not just in your finals, but for your entire career?
Look, this isn't just a simple checklist to memorize. It's a way to demonstrate clinical insight and logical reasoning. Following this method shows an examiner that you can actually think like a clinician. And honestly, this is what separates a basic, just-about-passing answer from a high-scoring, really impressive one.
Ultimately, this systematic process is your safety net. It makes sure you don't miss anything important, and it guides you step by step towards an accurate, well-reasoned, and totally defensible diagnosis. So, the real test? It begins now, with your very next patient. Go forward and apply this method to every single case you see. Practice turning a simple symptom, like a cough, into a complete, evidence-based diagnosis. That, right there, is the art and the science of clinical medicine.